very much. Wow, it's so great to have CGI back. I am beyond thrilled. We are focused in this session, please sit down, as you just heard, on reproductive and maternal health, because we view both of them as challenges and even crises that have to be addressed. Because across the globe, the rate at which newborns and mothers are dying still is staggering and shameful. In 2020, an estimated 2.4 million newborns died worldwide, and globally, more than 800 women die every day from preventable infections and complications related to pregnancy and childbirth. Now, these numbers are just really a flash into the reality of what's going on, because we know it's a lack of access to quality health care facilities and services. We know that we have a global nursing shortage that has only worsened since the COVID pandemic. And of course, there is either an inadequate attention at the policy level toward reproductive health and gender-based violence, or an actual indifference and even hostility. So we want to help lift up these issues to make them the global priorities that they deserve. Today I'm really proud to invite to the stage Mejdi Osman from Nubia Health, Tony Azel from BD, and Jose Luis Castro from Vital Strategies. And we are proud to announce these new commitments that will target many of the challenges that women face when it comes to the well-being of themselves and their children. Becton Dickinson will partner with the International Council of Nurses to help reduce the worldwide nursing shortage by investing in nurse and midwife training, as well as the products, programs, and partnerships needed to improve safety, productivity, and resilience among nurses and midwives. Now, these kinds of priorities are especially acutely needed in certain parts of the world. And there are some chairs up front for those of you standing in the back if you want to come out and come on up. In Sudan, for example, where the burdens of preventable disease and population growth pose significant challenges to healthcare overall, Nubia Health and its partners will build a new maternal and child health center in Wadi Halfa. So as people return to Wadi Halfa after years of displacement, they are finding that the existing healthcare services are not sufficient. But this center will provide basic maternal and child health care, community-based education programs, and training for community health workers, as well as serving as a regional hub for innovation, research, and training that will help to improve the quality of life for many marginalized communities in Sudan. And then finally, Vital Strategies will expand on its successful work in Bangladesh, Rwanda, and Uganda in tracking maternal, child, and adolescent health indicators to improve health outcomes. This next phase of programming will use data systems to combat unsafe abortions, improve sexual and gender-based violence prevention and treatment, and expand access to reproductive cancer treatments. In addition, Vital Strategies will provide technical and financial support to governments to bolster data infrastructure to integrate sexual and reproductive health criteria into routine monitoring, and then to use this data to drive policies. So these commitments really have the potential to improve and save lives around the world, particularly women and newborns who are the most vulnerable to poverty, violence, and yes, the effects of climate change. So I want to thank each and every one of these commitment makers for really helping us make a difference. Next, I would like to call Michelle Morris of the New York City Department of Health and Mental Hygiene to the stage. Now, you've just heard me talk about Sudan, Uganda, Rwanda, places where the crisis of maternal health and the lives of newborns are especially acute. But alarmingly, the United States is one of the only countries in the world in which the maternal mortality rate has risen over the past 20 years. If you take nothing away from this session, of course I think and hope you'll take a lot away, take away that statistic because it is so shameful. New York is ranked 23rd in the nation in maternal deaths, which is actually an improvement over a recent ranking of 46th. And nationwide, there are dramatic disparities in maternal health outcomes, with worst outcomes among Black women, underemployed, and underinsured people, and of course, individuals living in places with inadequate access to maternal health facilities. Black women die in childbirth in the United States at more than double the rate of white women, with many of those deaths coming as the result of infections and complications that with better care could have been prevented or treated. While Black women comprise over half of pregnancy-related deaths in the United States, they only account for 14% of all live births. So the disparity, the inequity, the shocking nature of this is something that New York intends to address. So I'm very proud to announce the Birth Equity Initiative, a commitment to expand the resources and improve the impact of the New York City Department of Health and Mental Hygiene's programs. This really innovative commitment will engage insurance companies, community-based organizations, professional associations, government agencies, advocacy groups, hospitals, and federally qualified health centers, all in an effort to reduce these inequities. And we will focus on Black women in Brooklyn and hope to see the reduction in these inequities within 4 years. Among other goals, yeah, that deserves a round of applause. Among other goals, the initiative will establish a maternal home model that refers pregnant patients to specialized programs, because especially if those patients are from marginalized groups, they may not very well have the primary and specialty care they need, the mental health services, and the support services that are required. I'm very excited about this commitment because I'm hoping it will serve as a model for closing the health gap for all women, but in particular Black women, not only in the rest of New York City, but literally across the state and the country. So I really want to applaud New York City for taking this on. Okay, now I'm very excited because we're going to have as I get my mic somewhere. Here it is. Going to have a conversation with two people who really are in the middle of working on these issues of maternal and reproductive health. Natalia Kanem, who is the executive director of UNFPA, and Javier Becerra, who is the U.S. Secretary of Health and Human Services. So please join me in welcoming them to the stage. Well, as you can tell, these are two of my favorite public health people, and two people who are really in the thick of trying to figure out how we're going to address these old and new problems, and that's something I want to talk about. Let me start with you, Natalia. Tell us just a little bit about yourself, because I think your background and what you've been doing is really key to addressing these challenges. And then explain how we ended up here. After all the attention, the efforts that we've tried to make on maternal and reproductive health, we still have a woefully inadequate response. And we are not providing the access and the support for the critical services that mothers and babies need. So give us a bit of an overview.
Well, great. Thank you so much, Secretary Clinton, Secretary Becerra. It was exciting to come in and hear the previous commitments. And it gives us a window into what we are up against, because by the end of today, 800 women will have died during pregnancy and childbirth. Now, as a pediatrician, I'm a medical doctor who shifted completely to the pregnancy side of the equation. Why? Because all the dots connect. And right now, we're in a situation where many of the Sustainable Development Goals are under threat. You mentioned climate earlier. Conflict is a reality that is contributing to death during pregnancy and childbirth. And of course, in a time of pandemic with health systems stretched, my training in epidemiology tells me that we have to have better ambition. And we also have to work through communities and trust women and midwives in particular to solve this conundrum. I can also tell you that part of the issue around access and agency means partnership. This is the excitement around something like the Clinton Global Initiative, and also with the Biden administration, stepping up to understand that a lot of lives are lost because the system doesn't work for the majority. And in a moment, if you ask me about humanitarian conditions, I'll be happy to expand on that as well.
Well, Secretary Becerra has such a distinguished career. I first knew him when he was a member of Congress and leading on so many important issues. Then as the Attorney General for California, now right back into the action, my friend. But what you may not know about him is his wife is an OBGYN for high-risk patients, and he has 3 daughters. So he gets it at home as well as at the office. You know, I want to acknowledge that you have publicly spoke about really your personal commitment as well as your professional one. Maybe you could share with us how you're seeing these issues now, Javier, the maternal challenges in our own country. We just heard about how we're the only country where maternal mortality is actually going up, which is so disgraceful. But also now, frankly, the new problems that are being caused by the draconian, restrictive laws being passed about pregnancy and childbirth. And, you know, that is an additional challenge.
Secretary Clinton and Dr. Kanem, first, what a real pleasure to be with you, because I think we are all looking for what we have to do next. And what I would say to you is that what I have learned, actually not as a doctor, but as an attorney and as a political leader, is that you can't sit because they're going to take whatever you're sitting on before you know it. And so at HHS, we are shackled by the Dobbs decision in many ways, but that doesn't stop us. Medication abortion has been around for 20 years. There's nothing that says that we cannot push as aggressively as possible, in fact, more aggressively than we ever have before, to make sure medication abortion is available to all women in America. There is... We're going to be challenged every step of the way, but we have a law, EMTALA, that is emergency care law, that simply says if you present in an emergency room and the physician treating you says, I need to stabilize you, and by the way, one of the ways I have to stabilize you is to perhaps deal with the pregnancy you have, and it may require us to lead towards an abortion to keep you stable and keep you alive. EMTALA protects that woman to receive the care she needs. There are some states that are already challenging us on that, but as I have told my team, we're not going to, I always tell my team, when you are put in a position to make a difference, never do mild, and because you don't get these chances very often. And so, Secretary, I think for us, it is understanding that we're about inclusion, not exclusion. We're about trying to expand the playing field, make it fair, not shrink the playing field. And you can't do that when you got a team on the field that's just playing without rules. And so you just got to go out there and, we got a good team and we can win. And I think we just got to go at it.
Well, I think it's an understatement to say, Javier, that the recent Supreme Court decision was a massive setback to reproductive rights, and the world is really watching to see how the United States, how our government, and how individual states are going to treat women and girls. And some are watching to see what they might be able to get away with if things are enforced here against women in the ways that will, frankly, damage women's lives and put some lives at risk. So can you give us a little more information, perhaps, about what we can learn from states that have policies that are supportive of women's health, solutions to how to get around these restrictive policies that are being imposed?
Well, the same thing that makes Dobbs a powerful tool for those who want to restrict access to rights and healthcare services helps us make sure that we can continue to provide them in states that wish to do so. So the right that we have in America to travel means that you cannot stop someone in your state from going to another place and engaging in activity that's lawful in that state. And so we're going to do everything we can, including consider ways to try to support remember, a woman who has to travel a long distance, maybe leaving a family behind for several days, needs to cover expenses. It is not an easy proposition. So we'll do what we can. The other place that we can make a difference has nothing to do so much with reproductive care to the point of conception. It's making sure, as you mentioned before, that we offer everyone, including a new mother and her new baby, an opportunity to grow up healthy. There are so many women in this country who are dying, principally in the Black community and the Native American community, at the time of birth or thereafter. And so we launched an effort, at least in Medicaid, to say if a state will join with us, we will make sure a woman is able to get not just the 60 days of postpartum care that she gets under Medicaid right now, but 365 days of care. And the state just needs to tell us they'll join in. And about 27 states have joined in so far.
I'm so glad to hear that because, infant mortality is the first year of life. It's not the first 2 months of life. And things can happen and go wrong that have to be dealt with by medical professionals. Natalia, you mentioned at the end of your opening comments about sort of the humanitarian challenges that are being faced. Can you weave that into a discussion about how sexual and reproductive health and rights is a woman's rights agenda and a human rights agenda. And it's not just about the individual woman or even about her family. It is about communities and societies. It goes, far beyond just one person, and we really need to understand the implications.
Well, look, for those who are not well aware, women's rights are human rights. And, and I quote, and soon after Secretary Clinton left the podium in Beijing, you worked on making the ICPD program of action, which assures that women have the right to choose when, whether, with whom, how often to be pregnant, came off the page and into policy. Look, we live in a world where there are 250 million pregnancies a year, 250 million, right? And of these, fully half, 47%, were never intended. So I'm talking of upwards of 120 million unintended pregnancy and childbirth events every year, unsupported, and sadly about half of those unintended pregnancies, and notice I'm not saying unwanted. We've updated the vocabulary on bodily autonomy because, of course, sometimes this is a delightful proposition, but unfortunately, better than half end in abortion, of which 45%, mainly in the developing countries where UNFPA, the United Nations Sexual and Reproductive Health Agency, looks after women and adolescent girls. 45% of these abortions are unsafe, and this is the hidden cipher under maternal mortality. So it is time for us to be vocal about the rights of an adolescent girl, the rights of a woman to be able to choose. And people are looking very closely at what happens in this great country, because setting the tone for agency, setting the tone for me, the 13 and 14-year-old who I've met, right, in developing countries, to be able to say my body is my own, to be able to report coercion, because this is another taboo, silent issue. All of this is part and parcel of those dots connecting. Now, when you throw conflict or even flood into the mix, right now in Pakistan, there are over 130,000 women who are pregnant. And we expect that there will be 42,000 deliveries in that country in the next quarter, meaning that you're under flood conditions. The midwife herself has been flooded out. So we really need to pay attention to how we protect and provide for women. For UNFPA, and again, US government can take fair credit for this, working with Syrian refugees across the border in Jordan in Zaatari camp, we're now over 10,000 safe pregnancies have not lost one mother, which is even better than the background population. But it does take resources. It takes us prioritizing. As part of the Nairobi commitments, when we celebrated 25 years after Cairo, we costed with partners, academic partners. UNFPA looked at how much would it really cost to put a major dent into death in childbirth for the world, not for my agency, not for your NGO, not for your business, for the world. Is $11 billion a year too much to ask? I don't think so.
I agree.
Yeah.
You mentioned midwives a couple of times. Talk about the role of midwives, because I think there's perhaps a lack of information or even, frankly, misinformation about how critical midwives are in most of the world when it comes to caring for a pregnant woman and then delivering a child.
Well, Hillary, you've already said it, and I think Secretary Becerra already alluded to, that we're talking about 365 days a year. And in terms of cost of care, the midwife is one of the most cost-effective propositions. The International Confederation of Midwives is celebrating their 100th birthday this year. They're part of the United Nations General Assembly contingent. And what I can say is that when we think of a midwife, we think about somebody who is going to hold your hand, explain your situation to you and your community, and who is a kind of leader of the health team who advocates for the well-being of women so that you're not over-instrumentalized, but at the same time, you get to the next level of care in time. Midwives, female health services are the most underpaid, not respected by regulation. And really, I think UNFPA is proud to partner with midwives because when we think about the life cycle, the midwife is there not just for the delivery, for the prenatal care, and now more and more working with societies where people are aging. We live in a very diverse population world right now, approaching 8 billion by November 15th. And as we think about teen pregnancy, which contributes a lot to maternal mortality, your body's not ready, your mind is not ready. We also need to think about what happens on the older age of the spectrum, and midwives are equipping themselves to do just that. I can also point to the fact that in this moment in time, in a place like South Sudan, we're seeing more male midwives being attracted into the profession. That has certain challenges because of custom and religion and other factors. But the point is that the nursing cadre, much more than our doctor cadre, deserves every ounce of credit for being cost effective, for being there before, after, and during crisis, and for being really smart in helping us decide what has to be prioritized.
You know, we had some commitments I announced earlier, and one was about the nursing shortage, Javier. And I think COVID, as I said, exacerbated that because so often nurses were truly on the front lines, and it was just an overwhelming responsibility. Are you looking, or is our government looking at more ways to incentivize the retention of nurses, the training of nurses, and particularly in this arena of, preparing women for pregnancy and delivery?
We not only are, but we've gotten more money in this last year and a half from Congress than we've had in quite some time because of the President's American Rescue Plan. We have been able to fund workforce resilience, where we allow the providers, whether at a healthcare center, a hospital, or a particular physician's office or other caregiver's office, where we give them flexibility to use the money to keep their workforce in place because we're losing so many of them because they're burned out. And rather than put strict rules on what they can do with the money, we try to make it so that they keep their workforce in place. We're trying to steer some of our graduate medical education slots into some of these areas where there's a real shortage. We're trying to boost up the number of scholarships and loan forgiveness programs that we target into some of the medical fields that are lacking the health professionals. And I will tell you, some of the best work that's being done is being done obviously by midwives, but also by doulas who are, they are also extremely qualified. But the great thing about doulas, and sometimes in Spanish you'll hear promotoras, these are individuals who actually give you not just the health care, but they're there for you and they become almost part of your experience. And so much of having a good outcome is about knowing that you can trust those who will be with you. And so we're trying to fund much more of that because what we find is that, especially in our communities that have never had great access to care, mostly Black, brown, underserved communities, folks are not accustomed to having an encounter with the medical community until it's time. And that's not the time you want to make it your first touch. And so we're trying to do everything we can. We did a session when we were talking about maternal health. We did a session with mostly Black women where some of the stories were extremely painful to hear. There were women who were saying, I would go to present before a doctor in severe pain, but it was tough to get them to believe me that I really was under intense pain. There are some studies that have shown that for black women, it is tough to get physicians to believe them when they say they are hurting or not in a good condition. And oftentimes the outcome is extremely in the wrong direction. And what we're finding is that more and more we have to have people who come from that lived experience to be the professionals who are offering you the care. And the final thing I'll mention is it was kind of embarrassing. I had a conversation after Dobbs with one of my counterparts from Argentina, the health minister from Argentina, and we started talking about reproductive health care. I can't tell you how difficult it is to believe that in the United States of America, I'm asking her for guidance on how we can increase access to reproductive health care in the United States, because Argentina now, in many ways, has laws that are more protective of a woman than does the United States of America. It is a total flip of where we should be, and I know that the rest of the world panics when they see the United States regress this way, because if we're not there leading, it is tough for the rest of the world. And so we, as I said, never do mild, because we have no choice. As Natalia has mentioned, there are so many people who today are looking at us, yearning for help.
Totally sign up to everything that you're speaking of in terms of women's lived experience being discounted. And also, there is a role for business to step up. When a workplace policy prioritizes, and I will even say parental leave, and a man can be respected because you're looking after your child, you're the babysitter today, rather than the butt of a joke, this is normal, right? Parenting takes a whole village. And I quote, moreover, there is a reticence, and earlier I used the word taboo, to talk, about things that are really real to young people who have built-in radar for people who are deceiving them and being duplicitous. So when we refuse to give young people information, and when they trip up and fall, when we penalize them, in many of the countries where we work, the United Nations has to defend the right of a girl to go back to school if and when pregnant. Even today at the Education Summit, which is being hosted at the United Nations, where is there controversy? So-called comprehensive sexuality education to protect a young person, right? Know your body, know yourself. Know what a relationship entails. So protective and so controversial. So I think we have to ask each other why. And I do expect, and I'm very grateful for, I see many of my friends in the corporate world trooped out for our session, for the understanding that we can make a difference, that girls should be given information, education, and a listening ear. And similarly, for everyone across the spectrum of sexual diversities. The world, in fact, should open up. We should be real about sex. We should make it safe for people to confide in a trusted professional rather than hounding the professional when they try to render assistance. We're back to rights. And I insist that for a young girl to navigate her adolescence safely is one of the best investments that we can make as societies. The evidence is so abundant. I mean, at minimum 9 to 1 on a dollar investment, and you can take it all the way up to over $200 if you use education and so many other vehicles. So I really expect us to speak up and speak out, and to allow young people to speak for themselves by giving them room on a platform. Thank you.
Amen, amen. When I was listening to both Javier and Natalia, I kept thinking about Serena Williams, who had to demand attention when no one would pay attention to the pain she was experiencing, and she was both knowledgeable enough about her own body and assertive enough to finally get that attention. And she was in very serious threats from blood clots. And so when we don't have medical professionals who are attuned to what they're hearing, even from highly well-known women like Serena, think of what it's like for everybody else down the scale of agency and standing. It's really quite terrifying. And then you get to young girls who are often dismissed out of hand. Natalia, when you think about the pandemic and climate change and the humanitarian crises that we are seeing around the world, we knew that there were already massive inequities in terms of health. Are there places in the world that you would like to identify as really trying to deal effectively with many of these issues?
Well, absolutely. And I think, again, the fact is that women have raised their voices, and in many places, things are changing. Not rapidly enough, but they are changing. So, for example, pre-positioning supplies for menstruation. Hello, this is normal biology. But for eons, we really did not have the so-called dignity kits with sanitary items at the ready as part of the response, which now more and more we do. There's also far more attention, and again, private sector partners get credit for helping us to light the refugee camps. The refugee agency now maps the new village of tents, basically, that springs up, so that if you're going to the latrine in the middle of the night, there is solar lighting, flash lighting, and ambient lighting so that you can feel safe on your way there and back. Now, catering for women in particular also means understanding that conflict magnifies the horrible statistic of sexual and gender-based violence that happens in every society, but of course is more acute in situations of upheaval. So the mental health label is actually not strong enough for us to understand that we have to reach out and help women who are in crisis situations, as we did, for example, for Ukrainian women, going to Moldova, making sure that information is given to you before you get on the bus, before you accept this ride. This is what you need to know about trafficking. Here is the hotline if you are undergoing domestic violence. And so the safe space and the legal and the judicial and the system that goes with it is part and parcel of humanitarian response, as is looking inward to make sure that predatory behavior of people who should be helping, but sometimes are wrongdoers, is rooted out. And this is what our Secretary General means by zero tolerance. And I've actually led that effort as the Sexual and Reproductive Health Agency to assure that women can have confidence coming forward to report, that every peacekeeper, that every humanitarian, the NGOs in communities, that we work in concert on that aspect as well.
It's so important. We've had, unfortunately, examples of members of groups like that taking advantage of young people in particular. Javier, I want to end with you because when we were talking about the inequities that sadly we still have in our own country, I worry greatly that those inequities are going to get much wider because of the reversal of Roe and some of the decisions that are being made in states. And as you think forward now as our Secretary for Health and Human Services with the team that you have working with states and cities, are there specific asks that you would have for our CGI participants as to what they can focus on to be of real assistance, like our two commitments that I announced, one which is, focused on New York City. Are there ways to, bring to bear federal, state, local, philanthropic, corporate, and other funding to really create some models so that people, when they come to you and they say, Mr. Secretary, what can we do? You can say, well, here's where to look and here's how to do it.
Well, I can go on forever on this one, but let me leave it to two principal areas. I think we saw what happens when we moor our rights and our protections in what we thought were safe waters of the courts. And the result is that Now we've been set adrift. And how do you get back? It's going to be tough. And so I think one of the first things we have to do is really be aggressive in making sure that we try to return the judiciary to what it's supposed to be, the neutral arbiter of the decisions that the political branches cannot make. That's going to be really tough because everybody now knows you get them as young as you can to serve on these courts for as long as they can, not because they're the most equipped or the most seasoned. And it's unfortunate because no one should have any belief that our courts are a neutral, non-political body. They're as political an animal as the Congress or the executive branch or any, as your home argument you have with your family members. And so I think one of the first things we have to do is really wake up to understanding that there is no safe harbor anymore for our rights and those protections. The second thing is very granular. There will be a woman, certainly in the U.S., likely in the South, probably from a disadvantaged community, who is the one who will suffer the consequences of Dobbs. And just a little bit of help so she doesn't have to think twice about whether she can actually take the 5-day trip to that state further north so she can actually get quality care. And it's hard to believe, but $500 could be the difference between this woman having her life and her family and her future and not. But that's where we are, and there are so many who step forward. There are states throughout the country, principally on the coast, a few states in the center of that are willing to step up. But they can't absorb the load by themselves. They need some help, and it's very simple. Planned Parenthood has been working this round the clock. It is just simply giving a helping hand to someone who's got to make a really tough decision. And the last thing they should have to worry about is who's going to babysit her kids while she's gone for the 4 or 5 days. And so it's very granular, but it's as real as it gets. And on the other side, we got to wake up. Nobody's going to give us a good court unless we fight for it.
Well, that's pretty wise, wise advice. Let me just end on a personal note because, if you've traveled, as the three of us have, around the world, you have seen so many different settings where women and girls are either being treated, denied treatment, unable to access it. And we know what that looks like. And the statistics that you heard earlier from Natalia really sum it up about the number of pregnancies, those that were not planned, those that end in unsafe or safe, but often unsafe abortions, all of those consequences. And I know that we have so many people here at CGI who are interested in this issue. And I hope that you'll talk to our staff going forward, be part of commitments like the ones you heard, because I have to end on echoing what Javier said. This is going to be a really rough time for a lot of women. You read about the woman in Louisiana who was confronted by the news that, there was no skull. There was, no capacity to continue developing, but there was a heartbeat. Such a strange and odd, choice for lawmakers to make. No brain development, but a heartbeat. And so the doctors in that hospital in Louisiana and in the area would not help her. And so she was getting sicker and sicker and needed the treatment that she could not get in her state. And just as Javier said, I think she went 1,000 miles away. So we want to get through this period of regression and cruelty and mean-spiritedness about women. But we want to save as many lives and protect as many women that we can while this is ongoing. So I can't thank the two of them enough. They're on the front lines, and we're so grateful to each of you.
Thank you. And thank you so much to Secretary Clinton, Secretary Becerra, and Dr. Kanem. I would now like to introduce the next portion of our program, our panel, Solution Makers. Please join me in welcoming Molly Jong Fast, Enid Mutoni, Aparna Hedge, Christy Turlington Burns, and Mary Ann Etiabet. Thank you.
Welcome, everyone. My first question is, I wanted everyone to sort of quickly introduce themselves and talk a little bit about how they got into this space. So if that's possible, should we start over here? Do you want to start?
Here. I'm Dr. Aparna Hegde. I'm a urogynecologist. I'm also the founder of the NGO called Arman that leverages technology to create cost-effective, scalable solutions to impact maternal and child health in 19 states in India. The story of Arman starts during my medical residency. One day, Rupa arrived convulsing in labor with hypertension. When I opened her papers, I was stunned. I saw my own handwriting. I had seen her in the 3rd month of pregnancy, but she never came back. I was racked with guilt. Did the overcrowding in the clinic mean that I had no time to counsel her about the danger signs, why she needed to access regular care? I saw these stories daily. Mothers dying in the most unjust of circumstances due to completely preventable systemic problems. If only they had access to the little information at the right time. If only the health workers were trained to pick up the risk factors and treat them in time. And I realized very early on that in addition to hospital-based care, I needed to go into the community to pick up these risk factors early enough, and ensure that these complications do not occur. And hence I founded Arman. Now, Arman is an acronym for Advancing Reduction in Mortality and Morbidity of Mothers, Children, and Neonates, but also a Hindi term which means an ardent desire. It's an ardent desire that no mother die for want of care. Thank you.
Hi, everyone. I'm Christy Turlington Burns. I'm the founder of Every Mother Counts, and I came into this work after becoming a mother nearly 19 years ago. I experienced a postpartum hemorrhage, which illuminated a global tragedy that I really was not aware of until I became a mother. So I like to say that I became a global maternal health advocate the day I became a mother. And I think really the sort of asking myself the question once I became aware of the statistics globally, which at that time, 500,000 or so more women were dying every year from pregnancy-related complications, and those numbers hadn't budged in decades. And I was shocked to learn that information. But I asked myself, what could I do? How could I take the experience and what I'd learned to try to help other mothers from going through this, from experiencing a complication or being ill-prepared for the complication that they might experience. I was fortunate to have options in my pregnancy, and I chose a midwife, and I had a doula, and I had a great team supporting me, but without that team and the care of a team-based approach to my complication and the postpartum complication that happened afterwards, I may not be here. I would maybe not have my child here. And so that's really been the path of Every Mother Counts, to raise awareness globally about this tragedy, but also to highlight the solutions, which there are so many of, which we got to hear a little bit about earlier. So we're all about bringing people into the conversation, making this a conversation that is not only for those who suffer or who take care of women, but all of us. Thank you.
Good afternoon. Enid Mutoni. I work for the Center for Reproductive Rights as the Chief Program Officer. The Center for Reproductive Rights is a global legal advocacy organization. We work on, we use the law to ensure that women, girls, and people access sexual, reproductive health and rights as fundamental rights. Why I work in this area? I always say that I'm actually one of those accidental positive statistics when it comes to SRHR on all the issues you can think about. I'm a 10th born child in a family of 11. My mother is Catholic. I never heard about contraception or anything like that until I was at the university. And so for me, when you talk about girls who've had botched abortions, when you talk about girls who've gotten married early, you talk about girls who never finished school. For me, those statistics are faces. Those are my friends that didn't make it. And so I don't want girls to be accidental statistics. I really work in this space so that we create laws and policies. That's my specialty. And also work in partnerships to ensure that women and girls and people requiring care and services access them as of right. Thank you.
Thank you. It's so great to be amongst so many maternal health champions, not just on the stage, but in the audience. My name is Mariana Tiebet, and 28 years ago, I lost my sister-in-law, 4.9 miles from where we sit today. And she also ceased during childbirth, didn't make it. That infant also didn't make it. But she left behind a daughter who is now of childbearing age, but as we heard earlier, actually has an increased chance right now of dying due to preventable complications of pregnancy and childbirth. And you can think about when she decides she wants to start that journey. Will she trust the healthcare providers that she goes to see, that they will listen to her? I know still my family asks, was there more we could have done? Did we miss something? What should we have been told? And that sense, that sense of the devastation in families, still exists. And so the work that we do, is so important. The inequities exist right in our backyard. They exist across boundaries, across geographies. And it's going to take all of us, to make sure that we're actually moving forward with progress and not moving backwards. I've been so lucky to be able to lead Merck for Mothers, which is Merck's global health initiative to help end preventable maternal deaths worldwide. Our CEO made a commitment back in 2011, $500 million. We were so excited that last year, as part of the White House Maternal Health Day of Action, we were able to actually reaffirm our commitment to maternal health with an additional $150 million commitment to this work. That work has enabled us to partner with hundreds of different organizations in 60 countries, and thus far ensure that over 18 million women have access to safe, high quality, respectful, and equitable maternal health care.
Thank you. So my first question is going to be for Enid. We're in this post-Roe America, and I want you work all over the world. So I was hoping you could talk a little bit about what it's like in the rest of the world, what this post-Roe America looks like to the rest of the world, and sort of where are we?
Thank you. I think I'd like to start by saying that, and this has been said in this room before, I think what has happened in the US has really been regression of unimaginable proportions. You're stripping away nearly 5 decades of a constitutional protection. And what has happened now is that we have a lot of, we have women and girls and people requiring services being left, at the mercy, for lack of a better word, of state protections. And immediately what we are seeing is that 1 in 3 women actually will be unable to access abortion. And for the center that works across the world, what does this mean? And I'd like to make one point first, it's that it's not about, when you talk about abortion restriction, because a lot of people, at the time people say that, they want to reduce the number of abortions. There's actually evidence that shows there's no correlation between restrictions and the prevalence of abortion. In fact, all that restrictions do is make abortions unsafe. So in a conversation like today, we are talking about maternal mortality, maternal morbidity. What we expect, and this has happened in the world and is documented, is that there's going to be actually an increase on maternal mortality, and we've already said that the US is already doing quite badly, and morbidity. The second thing that is going to happen, and we've seen this in the world, is that there's going to be targeting of women and girls and people accessing services for prosecution. We've seen that, for example, in a country like El Salvador, women in jail for up to 30 years because of obstetric emergency, not because of a confirmed abortion. It's obstetric emergency because you'll start seeing it here. The chilling effect of this law is going to mean that doctors will even be scared to treat a woman who presents with, with miscarriage and incomplete abortion, and they'll not be able to provide post-abortion care. And we are also seeing that across the countries where laws like this exist, it's actually doctors who call the police on their patients. And so the question of confidentiality, we have cases we are trying to follow up with question of patient-doctor confidentiality, the question about the trust that the patient has with the doctor actually goes away. We've just recently also seen that even other service providers, pharmacists, are also not able to provide services, and we are actually now seeing that we are seeing that as a center, we are increasingly having to represent doctors and their patients in court because they are being charged for murder. But just to also say, because you've also asked that, what does that mean? Actually, the US, and I'm going to quote that for you, the US is one of the 4 countries that has actually regressed in as far as abortion laws are concerned. The US is in the same league now with Poland, El Salvador, as we're talking about abortion, abortion laws. Over 60 countries have actually progressed as far as abortion laws are concerned. We just saw very recently Colombia passing a law that decriminalizing abortion up to 24 weeks. We also know that Mexico has taken a similar route. And so really, and I think the Secretary mentioned this earlier, the US can no longer hold its head in global spaces when you're talking about sexual reproductive health and rights, because you are no longer the leaders in that conversation.
I'm going to go to Dr. Aparna, who is going to talk a little bit, hopefully, about India actually has a Medical Termination of Pregnancy Act that was passed in 1971, but you still really struggle with maternal mortality. Can you talk to us a little bit about some of the obstacles to maternal and reproductive health that's in India?
Yeah, so India accounts for 9% of global maternal mortality. In the next 1 hour, 3 women are going to die due to childbirth somewhere in India. And there are pervasive systemic problems responsible for the same, right? So there is this single-minded focus on ensuring hospital-based childbirth. But there's no equal emphasis on primary care and referral system and antenatal care. So what happens? 86% women deliver in hospitals, but only 21% get full antenatal care. Right? So when you don't have access to primary care, women do not get information about how to take care of themselves and their children. And on the other hand, the continuum of care, which means picking up risk factors, treating in time, referring in time, is poor. Why? Because the health workers at every level of the health system are not trained, do not have knowledge, no confidence, and no motivation. So what happens is that you have delayed and complicated referrals or irrational referrals, leading to the overcrowding of hospitals where I did my residency, right? So there was, the rush of patients was so huge, I dread to think of what we did during my residency days, right? And that leads to maternal child mortality and morbidity. And undergirding all of this is the severe gender disparity and the inequity faced by women in India, right? I mean, even health workers, they face extreme patriarchal dynamics in the community that they work in. And there is no accountability within the health system or capacity within the health system, and there's a whole lot of gaps in staffing and infrastructure. But there's one point I'm going to raise here, and that's something that really bothers me as a urogynecologist, right? The concept of maternal health ends with delivery. 1 in 3 women suffer from pelvic floor disorders resulting directly from childbirth, and US is going to see this now. But the only condition that has got its due status is fistula. But countless other women suffer from prolapse, leaking of urine, leaking of feces. And it's an emergency, but a silent emergency because it deals with part of the body that women need to keep silent about. A lot of stigma attached to it, right? But the suffering is immense, right? I have seen women, last week I saw a woman, she had prolapse of her pelvic floor organs 2 months after delivery, but she didn't come to us for 2 years because of COVID. And the prolapse got ulcerated. She couldn't pee because the prolapse was obstructing. She was retaining urine. So by the time she came to me last week, her bladder muscle had failed, her kidneys had failed. I couldn't help her. In certain communities, women cannot pray or not allowed to pray if they leak even a drop of urine. However, there are no international or national guidelines on how to train health workers in prevention, screening, and treatment of pelvic floor disorders resulting directly from childbirth. There needs to be a movement, really, to really ensure that the concept of maternal health expands to include pelvic floor morbidity. Right? It really means a lot to me. Yeah.
Thank you so much. I'm gonna ask Christy. We've talked about. Yes, I'm going to ask Christy we've talked about health disparities. Talk to us in the United States what you're seeing with the inequalities and also how you're seeing this sort of post-Roe world open up in America.
Well, I think access to safe and respectful maternity care is inconsistent the world over, and equitable access especially. But what you find in this sort of post-Roe period of time, or what's most concerning, I think, is just that the communities that are already most susceptible or disproportionately at risk for experiencing bad outcomes related to pregnancy and childbirth, those outcomes are going to get only worse, which I think has been sort of explained here and previously. I just wanted to sort of mention that it's very true that we're all sort of talking about maternal mortality and how horrible that is, and yet the morbidities, I mean, for every maternal death, there are up to, I think, almost 100 more cases of morbidity, right? Like women who are suffering lifelong disabilities, painful, traumatic experiences that they will they will carry for the rest of their lives. And I think that we can't underestimate that sort of impact. The silent traumas and emergencies that we don't see, the statistics that are still very, very, they're not talked about enough. So yes, whether you are a Maasai woman in Tanzania, a Mayan woman in Guatemala, or a Black and indigenous woman here in the United States, access to safe, respectful, quality care must be something we continue to fight for.
Thank you. And I have one more question for Enid. I love the clapping. I think we're doing well if we've got clapping going. One more question for Enid. Beyond abortion, can you talk to us a little bit about the other rights you are fighting for, the rights that are at stake?
Thank you. And I think, we've started having some of those conversations here about the fact that when you talk about the right to abortion, it's much more than just the service itself. First of all, I think for us at the center, we actually see abortion as a right. And it's a right because it's also underpinned by a couple of very fundamental rights: the right to decide, bodily autonomy. But other than that, it's linked to other civil liberties, including, as we're talking about here, right to health. But on a broader context, what we are actually seeing and what we've seen across the world is that there's an actual attack against the broader women's rights, gender rights. And we know that usually the rhetoric starts with abortion, and they'll go next for rights of LGBTQI community to access services. We know already the right to contraception in some of the countries where we work is also very threatened, especially in Latin America, and it's linked very closely to the fact that it's also seen as a means of abortion. And we also know as well, and we've seen this again in the world, that other rights, including the rights that the UNFPA representative talked about here in the morning, earlier on, adolescents' rights. Across the world, right now, when you talk about being able to make decisions and questions around consent and capacity to be able to make those decisions, we see that amongst, especially amongst adolescents right now, the question, for example, of girls and boys of very close age being criminalized, for their sexuality. This is one of the areas that the center is working in, and there are thousands and thousands of boys in prisons because of this. So, and when you start talking about, especially in the global space, when you start talking about adolescent SRHR issues, then the question of abortion, morality, and social norms and customs are brought in as one of the reasons why nobody wants to discuss that. So I think for us, and which is why, a lot of times when we sit in, public health conversations at the center, we always the ones sitting there talking about laws and policies. Really, sometimes no matter how well you set up the health systems, no matter how well you have the services and the products there, if the laws and the policies are causing people to be scared to access the services, if they are causing stigma, and if they are giving doctors, they're chilling doctors from giving services, then unfortunately we cannot be able to really achieve equality and health for all. So for us at the center, we always call upon multi-stakeholder partnerships. We're working very closely right now across the world with health service providers in the associations, pharmacists. We also work very closely with the midwives across the world, because we are actually trying to say that increasingly, especially in terms of services on SRHR, these service providers must be seen as women's rights defenders. They are being targeted for providing a service that they've been trained to provide because that service has been criminalized. And many of them do not have laws to stand on. Many of them are not in their own communities, they feel threatened. So really, for us, the law must also be looked at, and the policies must also be looked at. But the service providers themselves must also be seen as people who also require to be protected. Thank you.
I'll clap for that. So my next question is for Marianne. Marianne, Merck for Mothers is from the private sector. Explain to us a little bit how you do that and what you do.
And actually, I think Ina just set me up. I don't know if you knew that I was going to make an announcement about a new commitment, but it speaks, exactly to some of the things that you were talking about. I also want to link it to what Anarpa said about sometimes we stop thinking about women after they've given birth. We also don't start thinking about women until they're pregnant. And so we not only need to think about how when women do interface with the health system across the pregnancy continuum, how do we use that as an opportunity to keep her healthy, optimize her life opportunities across the life course, and do so in an integrated way that deals with all of her issues and the needs and the preferences and what she needs to stay healthy. Moving back, how do we start with youth, not just girls, but boys as well, who are thinking about what they want to do in the world as they grow up. We started to talk about some of our children, and they test us. They have really big ideas about what the world should be, and it's our responsibility to create those platforms that allow them to live their best lives. And so I am just so excited to be able to announce a new commitment through a collaboration that we're doing with Girl Effect. And I don't know, Leah, are you here? Great to see you. Where we want to ensure that there is equitable access to family planning information for the youth of today. We're starting in Kenya. We're going to reach adolescents where they are. If you have teenagers, you know that this is where they hang out. And we want to make sure that not just meeting them where they are physically, but also where they are spiritually, metaphorically, and so that they can have those conversations about what they want to do in the world. And believe me, we need them in order to achieve these sustainable development goals, in order to move forward. And so the commitment is $1 million. We hope that all of you will join the partnership, because that's not going to be enough, to do this work, but really putting it as a challenge, because it's going to take all of us. And what's exciting about this partnership is linking together all the efforts that already exist to share information with young people, to link them to services, so that they can get what they want, when they want, how they want it, and where they want it. So that's our vision, and we're excited to be able to launch that today.
Christy, Every Mother Counts invests in women-led, community-centered organizations. Can you explain to us a little bit about what that means?
Yeah, I mean, I think we all of us in this room kind of understand that the experiences of people in communities are some that we may never fully understand, and so we've always believed in our grant making and in our sort of storytelling and the amplification of the stories that we share to highlight models of effective models of care. We've learned that it's in the communities themselves that the expertise is, and so really sort of listening to the women and the leaders in those communities to tell us what they know better than any of us really could, and to lean in around those needs and to support them in the way that we can. I loved hearing Secretary Becerra talk about doulas on the stage. I think that's a first for this conference, at least in my time participating in this conference. But we try to see ourselves as doulas for community-based care providers and direct service providers. They need the support that we're advocating for women to have, which is a wraparound sort of services of support.
That's great. And Aparna, will you talk a little bit about what Arman does with technology and in India and services like that?
Yeah, so, India's magnitude of the problem is so huge. It was very obvious to me that we have a design for scale from the very inception. And when the mobile phone came to India and spread through the country like wildfire, it is very obvious that it is an incredible tool to reach out to women directly and the health workers alike, right? But technology alone is not enough. We use a tech plus touch approach, meaning we leverage the existing health infrastructure and health worker network of Government of India, so that, we do not create a parallel network of our own health workers. So the programs are scalable and cost effective. All our programs are in partnership with the Government of India and the state governments. And we shift focus from hospital-based care to antenatal care, primary care, and referral system. So on the one hand, we inform women about the care to be taken during pregnancy and infancy. So we have programs called Mitra and Kilkari in collaboration with Government of India that are free voice call services that send timed and targeted preventive care information directly to the phones of the enrolled women through pregnancy and infancy, hand-holding them. So there are multiple tries for every message. Mitra also has a call center and a missed call system. Right? Kilkari has reached 26.7 million women in 18 states in India. Thank you. Our hope is that when women are informed, they'll access care. On the other hand, we train health workers at every level of the cadre, right? Primary care and referral system. So our program, again in collaboration with Government of India, called Mobile Academy, is the only mHealth-based refresher training program for frontline health volunteers called ASHAs in every village. Again, we've trained 252,000 health workers in 17 states of India. We also have a program called Integrated High-Risk Pregnancy Management, in which we train the midwives, medical officers, and specialists at every level of the primary care and referral system. Our goal is that in the next, by 2030, we reach 70 million women and train 850,000 health workers. And we're going to go into multimedia approaches, two-way communication, long-term hand-holding in all these programs.
Yay. We're getting this scary please wrap up thing on the teleprompter. So we're going to quickly just go around our panel, and we're going to just sort of a sentence or two about the sort of solutions you're working on or what you're hoping, whatever you want to talk about. Start with Marianne.
So we all need to be in this together, but we need to be guided by girls and women at the center. They need to be the solution shapers.
Just to add on to that, again, it's a question of if we don't lock it in the law, they'll get it. So we also have to pass the laws.
I think collaboration and partnership is very much represented here on this stage and in this room, and so I look forward to partnering with you all to make sure that we can make pregnancy and childbirth safe for every mother everywhere.
So I want to talk about equity. You need to have an equity-based lens, especially in a country like India, and gender transformative approaches, and also understand how our programs lead to actual empowerment of women and health workers in the field.
Thank you, Mom.
Okay, now I am going to introduce, I was hoping you could welcome the Right Honorable Helen Clark, PMNCH Board Chair and former Prime Minister of New Zealand.
Well, good afternoon, everyone. You know, it would be very easy to feel overwhelmed by the world in which we live at the moment. There's so many shocking things going on. But having sat in this room and listened to these wonderful panels of the last hour and a half and more, I'm not going away feeling overwhelmed. I'm feeling really energized because I feel we had solution-oriented, passionate people here who want to make a difference for what we care about, which is the right of every woman and girl to bodily autonomy, to have control of their fertility, to make their own choices, to have access to safe services, and to be able to fulfill potential. So it's the old saying from the Labour movement that applies really, don't get mad, get organised. And that's the spirit I think was coming through today. So we were reminded of so many things. Hillary Clinton reminded us that we're not talking about issues that affect only women and girls in low-income countries. We're talking about a challenge to women's rights that goes across the spectrum of the incomes of countries. And we're all shocked by what happened in the United States of America and the fear that it might embolden people who like to make these sorts of changes in other parts of the world. But then we're also reminded that there's 60 countries that have actually moved forward on sexual and reproductive health and rights. So we can take encouragement from that. And a smack in the face, which is what the American Supreme Court decision was, it will get pushed back. I was reminded, sitting here, of many years ago, late 1970s in New Zealand. The New Zealand Parliament got carried away and passed more restrictive abortion law. You know what the NGOs did, the civil society? They organised flights to Australia. And flight after flight after flight went out of Auckland and Wellington to New South Wales for women to have their abortions. The politicians were shamed into changing that law. And let's hope, we can see that kind of fight back in this country as well. Now, so we're here, we're rallying for these challenges. And I just want to make very few points about rallying. Firstly, it was wonderful to hear the affirmation of the role of our midwives and of primary care. I was once made an honorary midwife in New Zealand. I'm not safe to practice, by the way, but I was the Minister of Health who introduced autonomous practice for midwives. In our country now, the midwife is the overwhelmingly predominant provider of prenatal, birthing, and antenatal services. We empowered our midwives, and I'm totally supportive of the profession and everything that it does with and for women and as advocates for women. So let's rally for them in their 100th anniversary year. Second, on rallying, I'm representing today Partnership for Maternal, Newborn and Child Health. We are a partnership global of more than 1,300 organisations. We advocate across the board for women, children and adolescent health. And a big initiative we have starting to roll out now is over the next year, we are aiming to involve 1 million adolescents in the Global Adolescent Forum, which will be largely an online event with a lot of local convening, but it's really to bring those voices of young people forward to talk about the world they want and the needs they have, which will most definitely have an emphasis as part of it on sexual and reproductive health and rights. The second major convening, of course, is the Women Deliver Conference next year in Kigali, in Rwanda. The first time that the Women Deliver Conference will go to the African continent. It's hoped that 6,000 women and girls will gather in Kigali and about another 200,000 online and through various regional convenings. So that will be a very important rallying point as well. Third point, President Cyril Ramaphosa of South Africa has agreed, at the request of the Partnership for Maternal, Newborn and Child Health, to lead a global network of champions at head of state and government level for women, children and adolescent health. And we're just so excited about this. And he will be shoulder tapping other leaders who really care about these issues with the aim of having high profile champions at that level also join the efforts of all of us represented here today. So I'm going away inspired, not downcast. It's shocking times, but you know, a crisis brings opportunity. And I think the mood here was to seize that opportunity and run with it. Thank you very much.
Thank you for attending the session. Please join us in the Grand Ballroom at 4:30 p.m.